Activate.
Hey, everybody. Welcome to this pink cloud. That's my serious newscaster face.
Yeah, I was going to laugh, but now that I didn't, it's way funnier.
Right?
You know
Yeah,
what I
that
mean?
is.
So
the
that everybody at home will be like, hey,
the
that
awkward
was not
silence. Anyway, hey, welcome to this pink cloud. I am DJ Kelly Reverb. There we go. We are a show that is about multiple pathways to recovery, mental health, and all that good stuff. Excited about our guest today.
Yeah.
But I'm excited that the equipment is actually working.
It is working beautifully right now.
And everybody give it up for somebody that's going to be working a new job.
I will be working a new job.
The Chafer. Give it up for the Chafer, everybody.
Chad LeMans says DJ/producer and potentially Batman?
There we go.
Mark. So
All right,
I mean,
cool.
you know, I have a potential
Well, but
to
you
be
got a
Batman
new
or whatever.
gig, right?
Yeah, I got a new gig.
Cool.
So I go down to Houston tomorrow or Jasper. And I got to to train out there at that place for a few days.
I know a fella named Jasper.
Yeah, that's what's up.
Hey, but I'm excited because this episode is going to be more about mental health. We're going to tie in addiction as well, but we're going to be talking biofeedback, which I am excited. So we will introduce our Zoom guest first, which is Brigitte Tidwell, all the way from Houston, Texas, and Lunar Recovery. How are you?
I am doing well today. Thank you.
All right. Well, thank you for making time.
Yes, of course. I'm super excited to be here, and thank you for giving me this opportunity to share what I teach my clients almost every day.
Sweet.
All right.
I like it. And then next we have one of my sister's besties, probably.
True.
But BHS in the house, and that's Berkner High School, everybody. Give it up for Christy Lewis. How are you?
I'm doing great. Thank you.
Well, thanks for coming in. I appreciate it. So my sister, Kathy Partridge Ward.
Yes.
Made this happen. And what she's been talking about, what you do, and then, you know, what your daughter does as well. And she's like, oh, you got to have her on the show. And I'm like, okay. And then finally, about 6 months later,
finally,
now we have you on the show.
Yes, I'm so excited. Thank you so much for having us.
Well, so I'm just going to go ahead and let y'all kind of freestyle and tell people what exactly biofeedback is about and the benefits of it and how you got into it.
Absolutely.
Yeah.
So I'll give a little bit of my background, and then Brigitte, you can kind of talk about yours. But my background's in biofeedback. So I graduated from UTA in 92, so a long time ago. Right. But I got lucky because they started cranking out a bunch of social workers who have a biofeedback skill, because they had a whole biofeedback department back then, which they no longer have at UTA. So that's when I started getting, just looking at biofeedback, understanding biofeedback is kind of hard. But I was really excited about it because it helped me with my asthma. So I had asthma at the time, and I still have asthma. Actually, it runs in my family. And so with the biofeedback modalities, I was able to just keep myself calm and help whenever I had some pretty bad asthma attacks.
Right.
So it really helped me, and I said right then and there, way back in the 90s, that I was going to have my own clinic one day and do biofeedback. And I do, and so I do biofeedback and neurofeedback. So that was way back in 92. Since then I've worked,
Well, so I got a question. So like, how did it work? Like when you were having like an asthma attack or something, how would you address it?
It's one of the things that we teach our clients is to breathe nice and slow, which sounds really simple. simple. However,
Yeah.
I have like a whole PowerPoint on that where I teach my clients. It's called heart rate variability training. And so really what you're doing when you're breathing nice and slow is you're helping in asthma case, you're helping your bronchial tubes open up and you're helping yourself stay calm. So you're tapping into that rest and digest or that parasympathetic response, which is the calm response.
Okay.
And because if you get hyped up and upset, then it makes the asthma worse. And so, I teach my clients just really on a daily basis. We incorporate heart rate variability training, which is just a whole separate biofeedback modality in itself. It's respiration and heart rate.
Right.
And it just teaches individuals how to, create a balance with their autonomic nervous system.
Right. Well, and like you said, because for a while, I had really bad anxiety, and that's why I was self-medicating with the alcohol and everything like that. But like you said, it's tough to tell somebody, when you're having a level 10 panic attack, breathe, the
asthma is directly tied into anxiety, because if you feel like you can't breathe, obviously you start getting anxious and upset and worried. There were several times I thought I would actually die.
Oh yeah.
And I mean, it's scary.
Oh, that's the
Trust
best.
me.
That's the best part.
I
is
love
when
it.
you think you're gonna die and then it just makes the whole thing worse.
That's my favorite part.
Man.
Is I love looking death in the face.
Yeah.
But I tell my clients it's a self-regulation technique, and so it's not necessarily a relaxation technique, but it's a self-regulation technique. And so you learn how to regulate your emotions, whatever that is, and whatever the situation. And so in my situation, of course, it was the asthma, and so I had to stay calm during an attack. And I've learned that ever since. So anytime anything happens, a crisis, anything, I immediately go into my calm mode because I've taught my body how to do that.
Right.
Yeah.
That's cool. I have a question for you. What's up with this alphabet soup behind your name? For everybody that's just listening, there is almost the entire alphabet.
There's some there's some that I have not heard.
Yeah.
The PSI-D, I've heard of the LCSWS. I've heard of that, and then the BCB and the BCN.
So I got my doctorate. That's that PSI-D. So I got my doctorate. That's just a doctorate in psychology.
Okay.
Yeah, and I got that in 2020. So that one's relatively new. And the LCSW I've had seems like forever.
Right.
And I'm also
you're a supervisor.
I'm a supervisor. And then the BCB and the BCN, I got those in the 90s. It's board certifications in both biofeedback and neurofeedback.
Okay.
So I'm board certified, and really that's kind of like having another degree in itself. You have to go through a lot to get those board certifications. So anyone who's listening, wherever you are, like if you go see a practitioner who's doing bio or neurofeedback, you want to search for someone who is board certified. And there's an actual site you can go to.
Okay.
Yeah.
And I have a question about the last one.
Go
What's
ahead.
the IMC?
Oh, that's the interactive metronome. I don't do that as much anymore, but I am certified with interactive metronome.
Is that like a piano teacher?
No.
So like kind of EMDR type things?
It kind of like that,
Okay.
but it's a whole separate,
Dual brain stuff.
Yeah, it helps.
Yeah.
Dual brain stuff.
Yeah,
I like
I believe that's the scientific term. Is dual brain stuff.
Of course.
Yeah.
But as far as my background, my clinic, I opened it up about 13 years ago, and we've been adding new biofeedback modalities since. So we do quantitative EEGs for assessment, and then we also do counseling.
Okay.
But we also do biofeedback and neurofeedback
She
training.
said we do counseling and looked at me and Chad.
No, well, I'm,
Do you do couples counseling? You do life.
You would only be so lucky as to have me in a couples counseling
life
session.
partner counseling.
Yeah, right.
So anyway, so we just add like new modalities. And those are some of the things that, are really helpful with really just about any population. But we see people with addiction, and it can be any kind of addiction.
Okay.
But we also see people with traumatic brain injury. We see people with anxiety, and a lot of times it's severe. It can be OCD, it can be trauma, PTSD, and ADHD, autism, chronic pain.
Bingo, Chad. She said autism.
Yep. And sleep. I mean, we can't forget sleep because that's what we wanted to talk about today. So that's kind of one of the new
yeah, I mean, look, everybody has trouble sleeping.
Sleep's a hot topic.
Yeah, I mean, it's tough, and it's an important topic because, I mean, if you don't get the right amount of sleep, then you're not firing on all cylinders, and it's not, and then, you know, it's just like at some point, you know, you have to sleep. And, you know, I noticed, like, when I was actively, you know, alcohol, it was just horrible sleep with the alcohol, and I have like slept so much better now. But now I know that I have a roaring case of sleep apnea. So that's
there you go.
Good times.
Bridget can talk to you. One of the things I always say at my clinic is, the more you know about what's going on with you, the more you educate yourself. Knowledge is power, and then you can make the changes that you need to make. So we really dive deep into what's going on with people, not just psychologically, but also physiologically.
Yeah.
And that's one of the things we like to educate our clients on, is what's happening physiologically, because I think it's motivating. And if you really know what's going on, you educate yourself, it's motivating for you to make those changes that you need to make.
Right.
Yeah, well, I mean, it's hard to, if you buy a brand new car off the lot and you're like, oh man, everything's fine. You don't know, and then all of a sudden it blows up. It's like, man, you need a check engine light.
Right.
You know what I mean? So that's what kind of, you know, we talk about that in the rooms and everything else too. It's like, once you kind of know what the issue is, then you can solve it. But like, if I don't have any idea of what the issue is, it's just a multitude of things. Then I have no knowledge of what to possibly do for it. How could I ever fix it?
It's one of the reasons we got involved in the helping people with insomnia in the first place was because of Brigitte. And Brigitte was going to school. I know she hasn't introduced herself, but she's going to school, and she got inspired by one of her professors about sleep. And she said, and I don't know if we said, but Brigitte's my daughter, and so we do this little mother-daughter duo
By the
way.
Fun fact.
Yeah, fun fact. And she got so interested in sleep, and she said, Mom, this is what I want to specialize in. I want to specialize in this. It's so important. And then so we started kind of morphing that into my clinic, and lo and behold, I mean, I wasn't assessing the way I needed to be. You know, it was just sort of this evolving knowledge base that we started instituting into the clinic.
Well, why don't we throw to Brigitte and have her speak her piece on sleep?
Yeah, so I don't know. I feel like I should kind of start from the beginning because I've been doing bio-neurofeedback my whole life. So I had the privilege to
way
have
longer
my
than your mom,
therapist mom.
Yeah.
And so from a young age, I knew heart rate variability. And so whenever I would have asthma attacks, I'd get really, really calm, you know, and I'd go and ask someone to bring me an inhaler, and everyone else around me is, you know, chaotic and scampering, and I'm just really calm, you know, doing my breathing, just trying to stay alive. And it really has been a tool that I've been able to use throughout my life, especially when I got to college. So when I went to Baylor and I got my undergrad in neuroscience, I was trying to kind of do something a little different than my mom, of course. I was a teenager. I was like, I'm not doing what you're doing. And then I ended up, you know, in the same field. I finished school and was like, oh my gosh, everything that I learned is what you do. And this is so interesting. And I had this class, like, you know, she mentioned, with this amazing professor, and he didn't go by the book. We were going straight off of journal articles and research studies. And we'd have a whole class every week talking about the biases in these papers, and also how we could improve, and what this meant, and all these different things, and all, you know, how complicated it is. But we spend like almost half or a third of our lives sleeping. And how important it is. Everyone needs it. And this guy, Randy Gardner, he even tried to prove that we don't need sleep, right? He stayed up for 11
Hey,
days and
there's a
some
lot of
change.
there's a lot of people that have done meth that tried to prove that too.
Oh, yeah.
After about
And
three,
it
after
puts them
about
in
3 days,
psychosis.
it's exactly.
So this guy, still today, he's alive. He's in a psychiatric center. And he gave himself symptoms of schizophrenia for staying up for 11 days.
Nice.
And I just was
That's
like,
pretty impressive, though.
right, no drugs.
11
with
days
that
is
one.
pretty impressive. Yeah. Right.
And so it's just how important sleep was. And then, in school, especially studying neuroscience, I was pulling all-nighters. That doesn't help. I thought it would. It doesn't.
Right.
And then COVID hit, and I went to go work with my mother for a year. And all I could continuously think about was sleep and how all these people coming into her clinic could benefit,
Sure.
by figuring out what sleep issues they had. And so after I left her clinic and moved to Houston to be near my fiance at the time, my now husband, and continue my career in neurofeedback, I went to school. I went back to school to get my LPC. And I had the opportunity to work as an intern for Lunar Recovery. And I was like, I found my people. I found my people that can't sleep. Right?
Well, it seems like pretty much with addiction in general, I was going to say it's probably either sleep or then there's PTSD, because I always am like, okay, you have baggage and you haven't dealt with it, and that is the cause of why, you're using substance.
Yes. And the wonderful thing that I get to do here at Luna that I absolutely love is apply the neurofeedback and the biofeedback that I've been doing and knowing about my entire life with these clients, giving them, I call it like a boost, on top of what they're already getting here, because I work at the residential facility mainly. And so even in detox, people will come in, and day 2 of detox, we do an EEG, we get a baseline, and we start treatment. And let me tell you, you can feel it because we use neurostimulation, right? So this is a form
I was
of
going to say
conditioning.
you said EEG. And what is
so a
EEG?
QEEG.
Okay, what is that?
That's an electroencephalogram, and that's going to be measuring
spell it, Brigitte, spell it.
Your
your mom's.
Oh, I wish. And
because I've heard of an EKG, but just never that.
Yeah. So
I'll
just
explain
like
what
an EKG.
Okay.
Yeah, go ahead.
It's like
Mom,
that. It's a quantitative EEG. What we do is we put a cap on the head. It has 19 different electrodes, and we simply record brainwave patterns.
Okay.
So brainwave patterns with people, some people have excess brainwave patterns. If you think of it like a bell curve, on the left side would be a deficiency. On the right side of the bell curve would be an excess. And so in the middle is the mean, where you want your brainwave patterns to be. So if any of your brainwave patterns fall outside the statistical number of 1.67, we'll say 2. If it falls outside of a 2 standard deviation marker, then those are the areas that we target for neurofeedback training.
Right.
So there's certain biomarkers. So after we record brainwaves, we generate a report, and the report compares the individual to a normative database. And so in that normative database, it's like being compared to a group of Olympic athletes, right? So there's going to be something that's dysregulated. So we look at those dysregulated areas, and then we're able to determine protocols, training or treatment protocols. And so what Bridge is talking about is they do some stimulation, which is neuromodulation, which you're actually doing something to the person.
Okay.
Or you
like
can
poking them with a stick.
Uh-oh.
Uh-oh, what?
Like it went away.
Oh, can you not hear?
Mm-mm.
Uh-oh. Fun. Well, here.
You grab those ones.
Trade out.
Okay.
We should be good.
Okay.
If they'll reach.
Yeah, I'm like.
All right.
That's always fun when that happens.
Yeah, you should be.
Here, I think your chair's on it.
Oh, could be.
Here, I got it.
There we go.
How's that?
Better?
Hello? Yes.
Yay.
Much better.
There we
I
go.
think so.
All right.
Can y'all hear me?
Yeah, we
Yeah.
can.
Okay. So when you do that normative comparison, we generate a report, and then we can see all kinds of pictures and things, and it's really, really cool. Assessment is so awesome, and when we're trying to assess for sleep, and the big thing I wanted to say, and Brigitte can really, go off on this, is we can look at certain biomarkers, and because your brain waves tell us a story. And so what we do is we match those patterns to whatever symptoms that you may be experiencing. So, for example, if you're experiencing insomnia, well, there's a certain biomarker that you can tell that the individual actually has insomnia. So if I have a new client come in and they're saying, oh, I've got this going on, and I look and I say, well, how's your sleep?
Right.
And then they'll say, well, I'm having a hard time.
Right.
And so I already knew that because I looked at their unique EEG because
Right.
it tells us that story.
Oh, it does
So
already. So you can look at something.
Yeah.
and
I can look
see-
at something
wow.
and see. And so like even with people who have issue, and Brigitte, you talk a little bit more about this, but people who have addiction have certain biomarkers for, they might be prone toward any kind of addiction.
Right.
And so that's going to be typically some excessive, a fast wave activity in the frontal region, and sometimes some excessive slow wave too.
Right.
And
That's
so
what Kelly has. Excessive slow wave.
Well,
That's right. Is there any?
something
I was going
I-
to say, Chad's like, is there anything to do with Kelly's incontinence?
I have mean. my brain waves are mean every time I come
That's
up
right.
against
Your
Kelly.
brain
They're
waves
mean.
are
Yeah,
angry.
very mean.
they're angry.
Yeah.
Well, what we do is we
So-
look at those and try to help the person to learn how to produce stabilizing frequencies.
Right.
And then that helps with the addiction or it helps with the sleep, whatever that is.
Sure.
And so at our clinic, we use a neurocognitive approach. So
Right.
we combine the neurofeedback with the cognitive, which is the psychotherapy.
So I have a question on this. So does insurance cover this, and how much usually does it run just for a diagnosis?
Okay, so typically speaking, insurance will not cover the neurobiofeedback portion. Typically speaking, it will not. Generally speaking,
Right.
they just,
Right.
it doesn't. So usually people will pay private pay. But if they're coming in and their insurance covers counseling, so the cognitive part of what we do,
Right.
Insurance can cover that if your clinician is in network.
Gotcha.
Okay.
So then, like, if your clinician's in network, or I mean, are you guys in? Like, I mean,
I'm only in network with one.
Okay.
And so, and because we do a lot of training, and so it won't cover with the neurobiofeedback, but it
right. Well, we could use Chad as a test subject, right?
yes, throw them in.
Yeah. Okay. Cool.
Well, it's funny that insurance won't cover it because apparently it works pretty well, huh?
right.
We have a pretty high success rate.
Yeah.
Yeah.
Makes sense that insurance won't cover it.
Yeah.
Yeah.
Yep.
Why would they do that? Why would they do anything that works? Anyways. I know Bridget was trying to say something.
What were you saying?
Well, no, this just made me think of, like, you were mentioning the biomarkers and stuff, and I see a lot of certain biomarkers that pop up, especially in the addiction population, and a lot of questions too when people are initially doing their EEGs. I've had people ask me, "Can you read my thoughts?" Well, no, we cannot read your thoughts.
right. What is my
and-
future?
Yeah, exactly. But I tell them this one statement, and they always look at me like, I don't know what you mean. And then after we go over the report, they're like, and I'm like, this isn't gonna tell me anything you don't already know about yourself. Our EEG doesn't tell us anything you don't already know in your head. We're just putting
Right.
it into words for the first time. You're experiencing
Sure.
these
It's
symptoms.
validating.
And then we're just saying, hey, we see that you're experiencing these symptoms. And I've
Right.
had people break down crying, being like, oh, this contributed to my alcoholism. I had a genetic predisposition that 11.6% of the population has to increase my risk. If I were to sip alcohol for the first time, it would make me feel normal.
Right.
It would make me feel kind of drunk. And so it predisposes those individuals for benzodiazepine addiction, for alcohol addiction.
Right.
And hearing that, they're like, oh, and that they can fix that by taking magnesium glycinate and helping their body naturally produce more GABA. Right. And I'm not a medical doctor, but that's part of the sleep regimen, right? Is usually there's some sort of imbalance in the circadian rhythm. There's some sort of imbalance in
what was that product?
levels.
What was that?
Magnesium glycinate.
Ah, there we go. Good job.
Yeah.
And is
there's
that available at health stores? And
Whole Foods.
We should all take it now.
Sprouts.
Instead of taking
NyQuil.
NyQuil.
I mean, obviously talk to your doctor first, but it can be found anywhere. And there's only like 2 or 3 types of magnesium that actually cross the blood-brain barrier to help you make that major inhibitory neurotransmitter, GABA, that is the only neurotransmitter we need to fall asleep. And if you can't make enough of it,
gabapentin came from.
Yeah.
Have you ever heard of? I mean, you work in recovery, so you know gabapentin for sure.
Yeah, they're trying to reschedule that drug by the way too, because it's been found in I think over 90% of people that have overdosed. They found gabapentin as well.
Oh, really?
So they're trying to reschedule it because it'll be a narcotic now, which they need to. That shit makes people crazy.
Does it?
Yeah, made me crazy.
Yeah.
So I can't take it.
Well, that's why I never took it.
Well, you didn't have a leg amputation.
No. But what's funny, and since you work in feedback, I noticed when I went to rehab, the first thing they wanted to do, and I think it's refreshing what you're doing, but the first thing they wanted to do was, oh, you're depressed. Check. Here's these pills, and blah, blah, blah. Anxiety. Check. Here's these pills. So like, it was like they didn't really want to, I mean, I could have said, just any sentence and he would have gone, oh, yep, that's why you're here. So
Bridget,
I think this is.
At your clinic, does the on-site psychiatrist look at the QEEG to help with all the medication for all the patients, or is it just for refractory cases?
Ooh.
So, Dr. Corey Walker is who we work with. That's our psychiatrist, and she's been wonderful. A lot of psychiatrists are a little, they're not sure what to think about some of this information because it's new. But, when you're in psychiatry and you're going in blind and you're doing this kind of let my client be their own scientist and see if this medication works, and it might actually make them worse. It could make them better. And you have something that could potentially help you narrow that selection down to find something that works for them. She's been so open to it. She's like, please. And we have people that come in here that have what's known as like spikes. Right. And they can cause tics, they can cause panic and overwhelm. And a lot of individuals with spikes will go towards anything that's going to calm down their brain. Again, that's going to include alcohol. It's going to include benzodiazepines, opiates. And all they needed to be on was an anticonvulsant.
Right.
And they didn't know that because they don't have seizures or epilepsy. And neurologists won't diagnose them with that because it's not seizures or epilepsy. And so an SSRI is only going to make things worse if they're experiencing depression or anything like that. So it's been really wonderful to work with her and kind of send her the cases of like, hey, I see this. They might benefit from this medication. And then they try it. And then they do.
Yeah.
Right.
Yeah.
Well, and I think that's refreshing that it can actually change the diagnosis instead of just, somebody on site just going, okay, well, this person is obviously depressed and this person is obviously, XYZ. And I'm just going to, just these 3 things, because literally everybody that I talked to that went in like to see the, I guess it's not he wasn't a doctor, but what is a nurse that can prescribe?
Nurse practitioner.
Yeah, nurse practitioner.
Nurse practitioner.
He was like, oh yeah, well, you're depressed. You're depressed. And I get out and we're talking to everybody and they're like, yeah, he said, I'm depressed. I'm like, oh, that's funny. He said, I'm depressed. So it's
there is a wave now. I think that psychology and is changing, and I think evolving, improving,
Right.
however you want to say it. We're now starting to see some QEEG assistance, for prescribing medication if needed. Like if you're not responding well to meds, we could look at the EEG and see what types of medications would work best for that certain individual.
Right.
That's called QEEG assisted medication.
Oh, okay.
And so a lot of psychiatrists now are starting to catch on to that and use it. And I think it's going to catch on even more, in the future.
Yeah. Well, hey, we're going to go awkwardly through to commercial here. We actually have Chad's mom, or the Chatter's mom, Lil Sheila, has a book out, and it is called 2 Calls, and here it is.
Imagine getting that phone call as a parent that your son has been hit by a car and is being life flighted.
2 hours before we got the call, Chad had called me to tell me it was the best day of his life. And then I get another call, and a stranger had found him, and they were care flighting him to a trauma unit, and that he would start praying for our family that we needed to hurry.
When you wake up on the operating table and they're like, we're going to cut off both your legs. And then I wake up and then one's gone, the other one's in an external rod system. It's just not good. The real kicker is that I've had all of these scars all over my arms, and that's all from complications resulting from drug abuse.
I never thought about giving up on him. Never. This is my son, and I know he's going to be okay. You cannot just have help for the addict. You have to seek out professional help. The whole family has been affected.
And I just want to make that very clear to anybody who's out there listening, that if I can do this thing, as much as I've been through, man, there's a lot of wiggle room for people before they get to that point where they can do it too.
All right. And that book is actually called 2 Calls. And if you go to 2calls.org, you can buy the book. And then also you and your mama do speaking engagements and speaking stuff.
Yep. So we go around and we talk to people, and it's kind of like a family-centered idea where we give out, free resources and stuff for families that are struggling, because she's right. The families play a very integral part in the recovery process. So yeah, we kind of go around and speak to people and see if we
and
can
then
help.
she's doing a rewrite on the book as well.
She is
right?
doing something else with the book. I don't know what exactly.
I want
like
a screenplay.
Well, you're not going to get it. I'll give it to every single person on the planet.
I want a screenplay, and then
the one thing we're not allowed to do is from a publisher.
And I want more
per the publisher. They said you can't ever give it to Kelly because he's a piece of shit.
Nice.
That's what they said.
That's great.
It was in the contract.
Well, cool.
It was in the contract.
No, but I was going to say I want to see a screenplay, and then the role of Chad is played by Morgan Freeman.
That would be so tight, dude. That would be so tight.
But anyway, we also have some music out.
Yeah, hold on just a second. This one is, I gotta grab it. Here we go on the desktop. Boom.
All right, and that is our new one that is out. It's a little Depeche Mode cover called Nothing.
Yeah, woo.
Yay. It's streaming on all major platforms. There is a playlist called This Is Kelly Reverb. Be sure and follow that, and then be sure and also follow the show, This Pink Cloud.
Yeah, follow.
While you're there. Follow
Follow the
Yeah.
show.
Well, so anyway, back to, I mean, we were going to talk about how, I guess you were saying something about addiction and sleep, right?
Yes, addiction and sleep. There's a high incidence of sleep issues or sleep disorders in the addiction population. Since that's what we're talking about, and
Right.
and so. One of the things we do is, like we said, we can look at the biomarkers on the EEG to see if the individual does have insomnia. But let's say they actually have two things going on. They have sleep apnea and insomnia at the same time.
Right.
Well, that's pretty common.
Yeah.
But if the sleep apnea is not being treated, then we can't help with the insomnia.
Right.
So we will refer out, and we refer to like a sleep lab or back to the neurologist or whatever, and make sure that whatever's going on with the individual that they're being treated. I've even had a girl, teenager, she came in and she had narcolepsy. And insomnia. And the funny thing is they diagnosed her with POTS syndrome. Do y'all know what POTS is?
No, let's hear it.
It's when you faint really quickly after you
Is it
like the little goats?
I was going to say being one of those goats.
Yeah, it's kind of like that.
Kind of.
But
it's like
kind
a
of.
vasovagal response.
It is.
That would not be good to have that in driving.
But she had graduated,
No.
and there was this loud clapping noise, and she was walking out from her graduation from high school, and she just fell to the ground.
Right.
And the mom told me, and they were like, "Yeah, that's the POTS." And I said, "I don't know. That sounds like narcolepsy to me." So anyway, she had the biomarker also for insomnia, but we were having a hard time helping her with her anxiety and everything. It was really complicated. So send her to the sleep lab. Sure enough, she had narcolepsy. So which is, it was just kind of interesting because we could see that there were some sleep issues on the EEG.
Right. Yeah. Well, I always thought that would be fun to have for just a little bit.
Do you remember the movie Rat Race with Mr. Bean, and he's in it, and he's like, "Oh, I won the race," and he falls asleep when he's trying to unlock the thing. Yeah, he just fell asleep everywhere.
Oh, nice.
Yeah. Yeah,
There
I
we
remember
go.
that.
Good stuff.
Well, obviously, if there's other sleep issues, we refer out. We refer out a lot.
Right.
But if it's just, anxiety kind of mixed with insomnia and some addiction.
Well, y'all do. It sounds like y'all kind of fine tune it, or maybe just get a better idea of what's going on.
Right. Well, we combine. We use a neurocognitive approach, and honestly, that's exactly what they do at Brigitte's clinic at the recovery place. It's a neuro approach, and it's a cognitive approach.
And what does that look like? So does that look, and Brigitte, I can throw to you on this. What does that look like when somebody comes in? Are you first asking them questions, and then is the cap of the cap of goodness, the cap of wisdom? Yeah, there we go. Or how does it work?
Exactly. So there is an intake process. We do have a couple questions that we do like to ask people, of course, including, their past treatment history and all of that fun stuff, their drug of choice, all the drugs that they have used in their lifetime. That lifespan of that trauma history is very important. We also do screen for a few other things as well to look to see if
Autism
they need.
in Chad's case.
Yeah,
Sorry.
exactly.
Way to class it up, Kelly.
Thank you.
We look for signs of vitamin D deficiency along with B.
All right, so I want to stop you. Hold on, I want to stop you there. I got a question. So the vitamin D thing, that is relatively new. I've seen that in the past 10 years. So do you know, what exactly is it when they say? Because I'm always low on vitamin D, and I'm like, what exactly is it that vitamin D, allegedly or practically actually does, if you have a lack of it?
Mm-hmm. So along with, the stereotype of vitamin D helping your bones become strong, vitamin D is also plays a vital role in your circadian rhythm. So if you have low vitamin D, it's going to be hard to sleep. And with lack of sleep, it makes life worse.
Sure.
It's going to be harder to clean your brain because that's what happens when you
Right.
sleep, right? Stage 3
Oh,
or
talk
deep
about
sleep
that,
is
Bridget.
where we have it's called brainwashing, right?
Okay.
And not in the way that you would think. It's your brain is literally
You're
cleaning
right.
itself.
Yeah. Gotcha.
Yeah, increased flow of our cerebral spinal fluid to our brain, bringing out all the trash that we've collected over the day. And so I know y'all are probably familiar with Alzheimer's. And the Alzheimer's hypothesis surrounds the amyloid plaques, right? Along with
Okay.
neurofibrillary tangles. Well, you and I, and everyone in this room, has amyloid plaque buildup right now.
And it's because of our deodorant.
Right? And that's just trash from thinking. And if you're an
Sure,
overthinker, congratulations, you have more trash.
Oh, right. You got the buildup.
Yeah. Yeah. And so if you're not sleeping well, you're not taking out the trash and you're going to feel groggy. And one of the first symptoms of Alzheimer's is having unsegmented sleep. So not being able to sleep for a long period of time. So sleeping 2 hours here, 2 hours there, 2 hours here, 2 hours there. Because you have that amyloid buildup. You're not able to get into the deep sleep, and then the neurofibrillary tangles build.
Right. Okay.
And so getting that deep sleep is important.
Yeah.
I have another question for you. Speaking of Alzheimer's, because I've looked into a little bit of this. Isn't there an explanation or another type of explanation that they're also giving in European countries for it that we are not currently recognizing? And is that valid whatsoever? It has something to do with diabetes, right?
Yeah, type 3 diabetes.
Alzheimer's is a third diabetes.
Yeah, and it has to do with the plaque buildup and all of that stuff as well.
Yeah. All right.
Yeah.
Well,
with research on that.
Nice.
That's a sugar addiction of your central nervous system. So that just means that your brain's addicted to sugar, and you're continuing to go back to it. It's causing interrupted sleep and slowly degrades your brain.
I'm over here checking boxes, man. I'm like, okay, sugar addict, yes. I'm like, fragmented sleep, yes. I'm like, yeah, I need to stop by.
Again, knowledge is power.
Yeah,
the more you
for
know
sure.
about this, the more you'll think twice before eating that, second piece of pie, at night.
Oh, well, I'm horrible about this. Is I'll sleepy is what I call it. Just wake up and just graze. And I'm like, then there's just like crumbs and like everything. And like my wife will be like, oh, well, what did Kelly have last night?
So, actually that you bring that up, that's really, really common, and something that's brought up here when I talk about sleep is, the 3 S's, what bed is meant for: sleep, sickness, and sex. And that's it. If you eat in bed, then you have now trained yourself to be hungry in bed. If you watch TV in bed, you have now trained yourself this is entertainment time. And so even if you want to do those things in your room, getting up out of bed and doing it in a different location is better than doing it in bed.
Right, yeah.
We call that with cognitive behavioral therapy for insomnia. It's a very specific type of therapy. It takes approximately 6 sessions over the course of 12 weeks. We track their sleep. We have the individual track their sleep. And basically that's called stimulus control therapy. And so we do stimulus control therapy, sleep restriction, and then talk about sleep hygiene. There's just so much that we can cover over the course of 12 weeks.
Yeah.
And then we encourage the individual to make very, very specific changes. We call it a sleep prescription.
Right.
And then we combine that sleep prescription with neurotherapy. And so there's a type of neurotherapy that we do that's very helpful with insomnia, and it's called SMR training. We train a certain frequency that's very stabilizing.
Okay, so let's talk about that. Let's go into that a little bit more.
Okay, so have y'all heard?
What does SMR mean?
sensory motor rhythm. Brigitte,
Are
you
y'all-
want to talk a little bit more about that?
I love how mom
Yeah.
and daughter
Ask
quiz each other. Yeah.
Yeah, SMR training actually was originally started. Well, actually, it's kind of like a fun story, but anyway, it was to train cats way back in the 1970s, and they discovered that.
That you can't do it.
Yeah, you can actually. So when a
Right,
cat like is in the zone, like right before he pounces, they're emitting this frequency from 12 to 15 cycles per second. It really helps you get in the zone.
Right.
And so like peak performers who play sports, like let's say before you hit a golf ball, you have to really, really like focus. They're usually like in that zone. They're probably producing that 12 to 15 cycles per second. Well, lo and behold, people who have insomnia are typically deficient in 12 to 15 cycles per second. That frequency. So what we do is we encourage them to produce that frequency, and it brings down the excessive fast wave activity and brings down the slow wave, and just helps with stabilization with the brainwave frequencies, and then improves sleep, and then if there's an addiction issues, the addiction can improve.
Okay. Cool.
Yeah.
All right. So I have a question. You keep saying cycles per second. The same thing as hertz.
Hertz.
I know that. So how do you actually go about? Do you like learn different activities that can increase these responses?
So what it is called neurofeedback. And neurofeedback falls under the umbrella of biofeedback as you're training your brain. But it's called operant conditioning, which means that you get both positive and negative reward. So in the case at my clinic, they're watching a screen in front of them, and we actually have it hooked up to Disney Channel or Hulu or whatever, and they can watch, if it's a child, a movie of their choice, but it has to be appropriate. But we want them to watch something that they want to watch. And so the positive feedback.
Watch The Exorcist.
Yes, no way.
Yeah,
Right.
and not scary movies.
Right.
No,
Yeah.
I have funny stories about that. But anyway,
Right.
I'm not going to say
Kathy
it now.
and I do too.
I'm
So,
sure.
yeah. We all do as
We all do.
children of the 70s.
Children of the 70s.
Yes.
But anyway, with the feedback, the positive, the clinician is setting threshold settings. And so let's say we want to suppress excess slow wave, excess fast wave. We suppress that and then encourage that more stabilizing frequency. So that's the reward. So if they're
Right.
meeting all the threshold settings, then their screen will stay big and bright. All right. But if they're not, then the screen will get small and dark, or it will become distorted in some way.
Right.
That is neurofeedback training. The client is doing all of the work. We
Oh,
just
wow.
provide the hardware and the software.
Now, are you telling them like while this is happening, hey, let's do
Hey,
this?
you suck.
And yeah, right. Hey, calm down there.
Their brain
You know?
Calm
figures
down,
out.
Jasper.
Their brain will
Right.
figure out how to train. So it's kind of like riding a bike. Like when you first learn how to ride a bike, you're a little like unsure, and you have to really work at it, and your body has to learn how to balance and figure. And then once you learn how to do it, you can not ride a bike for 5 years and get back on the bike. Your body knows how to do it.
Right.
That's how neurofeedback training is. You don't quite know that how you're doing it, but your brain waves, your neural pathways will
Oh, yeah.
form. It's really just it's causing a state of
Right.
neuroplasticity and change.
Right.
So your neural pathways will form more effective modes of communication. That's what neurofeedback
Well,
is.
and
It's just
that's-
improving neural communication.
Right. And I kind of learned that in recovery.
Yeah.
They were talking about that. It's funny that you carve neural pathways to
Yeah.
do certain things. So in order, like, for example, I used to be a big fan of the old vodka in the water bottle in
Yes.
the freezer.
Yes.
So now I just have the Mio in the same spot, and I'm like, oh, okay, cool.
Right.
It's just it's a healthy trade. But I mean, it's funny because I find myself still, reacting whatever would make me drink. It's like, oh, okay, cool. Even though I'm hitting the Mio now, but it's still that same kind of trigger,
Thought process.
Yeah.
And that is a trigger. But in this case, well, it gets pretty complicated, but in this case, what we do is we do subsequent QEEGs, and we do comparative analysis and look at the changes, the physiological brainwave changes that have occurred since the training, and then we adjust the protocol accordingly.
I have a question. So, has there been research on actually using outside external waves to manipulate brainwave activity and to try and combat like that?
Brigitte, you want to talk about the neuromodulation?
Yeah, so that's kind of what we do here. So it's still a form of neurofeedback. It's known as neurostimulation. And so it's similar to like a TENS unit that you would use for your muscles to stimulate
Yep,
right.
your muscles to help
Talking about a
with
CES
blood
machine?
flow and all of that.
Yes.
Yes, and so we put electrodes on the head, and it has a very, very low milliampage. I think it maxes out at 2.5. Everyone here loves going all the way to 2.5.
It's alternating current
All
or
my
direct
clients,
current.
yeah, alternating or direct. And all the clients are like, shock me. I can't wait to get my brain zapped.
We use the word zap.
And love it because, well, they love it because they feel something. They feel
And it's very
something
mild but
afterwards.
pleasant.
Well, I mean, there used to be in the 70s, 60s, and all that kind of stuff. There was shock therapy.
They still do that.
Yeah,
some
they
places.
still do it.
Yeah.
It's a little, in my opinion, a little barbaric
More
now.
intense.
But we
Yeah.
combine it with a magnetic therapy, pulse electromagnetic, therapy. And
Okay, so explain that. Explain how that part of it works.
We just put a certain frequency on. Let's say you have a deficiency in a certain frequency. So we'll turn it on that frequency, and the brain waves will entrain with the frequency. So what we're doing is creating a state of neuroplasticity or change. Yeah, and then at the end of that, and of course our clients like, wow, this feels great. So let's say I have someone come in and they have like really, really high anxiety. And this is a true story. This has happened several times recently even. We'll put two electrodes behind the ear at the top of the mastoid, and it gives a little pulse and helps to activate the vagal nerve, which causes a feeling of calm. And at the same time, we're doing the PEMF on the head. It's just these little magnets, and your brain waves will entrain. So we have one particular protocol called anxiety reduction. And I'll actually have people love it so much. They leave and they're crying, but happy tears, and said, I did not know what it felt like to feel calm. Like, is this what it feels like? I actually feel calm right now.
Right.
And
I have another question.
And some
I
of
was
my
going to say,
clients, they
go ahead.
relate it to being high because they haven't felt calm before. They're like, I feel this lightness and relief, and they want to go back to get more.
Well,
but it's
and
healthy.
that's what I want. I was going to say, my personal experience with anxiety, once I was able to not have it on a regular basis, because basically what I found out is that, the temporary solution was the problem.
Yes.
Really. And then until I gave myself time away from that, then I was like, okay, well, I'm still going to be anxious here and there, but that's just part of the show, and you just need to learn to deal with that. But yeah, I mean, to what you were saying, but what
I
did you have?
I have a different question to ask now, since we covered the brain wave, for lack of better terms, manipulation. Right. What are the implications of something like that? Like learning it, that could be like, I don't know, dangerous in the future.
The only negative side effect with the type of neurofeedback that we do is feeling a little bit tired after the session. And it's kind of like giving your brain, workout, like, when you're lifting weights, you feel a little bit tired. Sometimes that'll last about 45 minutes. Sometimes it'll last a couple of hours. Also, sometimes if you train too long or if you overtrain, it can be irritating. So you have to do the neurofeedback training with a trained practitioner.
Yeah.
And someone that's certified in the field, because there are some people out there that don't understand, or they don't know what they don't know, and you just need to be with people who are trained.
Okay.
Sure. Yeah, probably a good idea.
Another thing Another negative side effect that will sometimes pop up, and I see this a lot in early recovery, is headaches. And these aren't headaches due to the training, but they're dehydration headaches.
Oh yeah.
And so
100%.
just like
Yeah.
you wouldn't go to the gym without drinking water, you're not going to come to my
Right.
session without drinking water.
Yeah.
So I always encourage, just drink a whole glass of water.
We're always handing
lay
out
down
water.
for a bit.
Right.
And
Right.
your head will feel better.
Right. Well, yeah, we find that caffeine works better if you stay hydrated as well.
Oh yeah.
Right?
Yeah.
Yeah, but well, I mean, we've got about 5 more minutes, so I just wanted to, anything that you guys.
The only other thing I was going to just to wrap it up. What we tout at our clinic is really building up your sleep drive. And really this can be in any population. There's so many people who have issues with insomnia. But you build up your sleep drive by staying busy all day. And we produce a neurotransmitter called adenosine.
Okay.
And so the busier you are, let's say you work out in the morning and you're busy all day, and then you sleep better that night.
Oh yeah.
Right?
Yeah.
That's because you've built up more adenosine. So you can attribute it to like thinking about maybe blowing up your balloon all day. So at the end of the day, at night, right before you go to sleep, you want your balloon to be big and taut, right? And if it's not, let's say you took a nap, or you didn't work out, or you just kind of laid in bed all day. Well, you're not going to sleep as well.
You drink a
that
bunch of
night.
coffee.
Or you drink
Right.
a bunch of coffee.
Sure.
So that will interfere too.
coffee-
And obviously, Brigitte, how does alcohol interfere with our production of the neurotransmitter adenosine, which helps us sleep?
Well, it's more coffee that will block it. It's a competitive antagonist, which just means it competes for the same receptor as adenosine, but it does the opposite effect. So instead of helping us feel tired, it helps us feel awake. And that's why we can get a crash after that caffeine wears off, because all the adenosine is coming and filling up all the receptors. And then we get that
something
crash
I found
adenosine
amazing
instead of a
about
gradual tiredness.
Right. And something amazing I found out about caffeine that I didn't know for a long time was that it's actually a blocker. It's not actually a substance that you're introducing. It actually, and I don't know what it is that it blocks, but
It doesn't do away with that adenosine, though. It just sort of blocks it, and then once the caffeine goes away, then the adenosine comes back, and that's why you have the crash.
Sure. Yeah.
Yeah.
But it's like, you think of caffeine, oh, I'm taking caffeine, and it's like, oh, it's, like you would like meth or something like that, but it's actually
And some people are more
blocking,
sensitive.
Yeah.
Some people are more sensitive to it. Like for me, personally, I'll drink probably 2 cups every morning, but I have to do it early. And if I drink any coffee after 12 o'clock noon, I have problems sleeping.
Sure.
So, and some people it's 4 o'clock.
Right.
But for me, man, I just have to be careful because I like my sleep.
Yeah, sure, of course. Yeah, you got to be cognizant of that because, if you're not, you're like just habitually, I'll have this stuff around and I'm like, okay, Kelly, it's like, after 10 p.m.
It's 12:30 at night.
It's 12:30 at night and you're still hitting the Mio, dude. No wonder you're up till 6,
Yeah.
But but yeah, I appreciate you both coming on. And go ahead. Did you want to say something, Brigitte?
Oh, the last thing I wanted to mention was in lieu with alcohol, when, alcohol, how it disrupts the sleep system. And it's very similar to, marijuana and benzodiazepines, is it takes out your REM sleep. And your whole purpose for REM sleep is memory. Right? It's storing things from your hippocampus to your cortex. And that's why we dream, is because we are trying to interpret all these neurons firing, strengthening or deleting memories. And we're not having that time because it's better to get stage 3 sleep and clean our brain first. Alcohol prevents that, marijuana prevents that, and so do benzodiazepines. And so if you take those and you're detoxing, you have very intense vivid dreams.
Yeah, I didn't realize that was it would actually do that with I guess marijuana and especially benzodiazepines, because I have taken benzodiazepines to sleeps. So
To
it's
sleep,
like,
yeah.
yeah.
Yeah, you can also take them
Well, and
to
it's
like
great
steal
if you have
cars and
nightmares.
stuff.
Yeah, right. Well,
Yeah, if you're awake, it's a living
interesting.
nightmare. No, I'm just.
Right. Yeah. Sleep
Has
paralysis.
this funny side effect called turning everything into a lick. That's what they say in jail whenever they get arrested.
Oh.
It's like, I don't know, man. All of a sudden, I just wanted to steal everything around me. Now I'm here.
Yep.
There we go. Well, okay. So let's real quick. Let's give both of y'all's places a plug. Bridget, we'll start with you, and then if they want to come, visit you in Houston, if they're in the Houston area.
Mm-hmm. Yeah. You mean at Lunar Recovery?
Yeah, I mean, in case anybody wants.
Give your website address.
Yeah.
Oh, yeah. So Lunar Recovery is in downtown Houston. We have IOP and PHP, including in adolescent services in the Galleria area. And we have our
Right.
residential house, what is a house with a pool. We have a massage therapist that comes. We
Equine
have
therapy.
a workout trainer. Oh, I wish we had
Right.
equine therapy. We have a personal chef, neurofeedback.
Right. Oh, nice.
Yeah, it's kind of a vacay.
It's bougie.
And that's in the Heights.
It is bougie.
So
Right.
2 different locations. One is in the Galleria
Okay.
area. One's in the Heights. The house
Okay.
has
I do
only
really
9
love that area
people
in
max.
Mhm.
It's beautiful. And
Okay.
every weekend, people get to go and do a sober activity.
Oh, cool.
So
Oh, that's cool.
And
they
then
get to
did you
kinda
have a
go out in the world
website as
and do
well?
something.
And did you have a personal
Yes,
website?
it should
Yeah.
be. I don't have a personal website, but it's just lunarecovery.com, I think.
Okay. You're
Let me
verifying
double
that.
check.
Well, they
Yep,
can
it's
figure it out.
lunarecovery.com. Mm-hmm.
All right. Well, I just want to say thanks for coming on, and then we'll have you go ahead and pitch
Sure.
where you're at.
So my clinic's over in the West Plano area off of Preston Road.
Okay.
And my website address is thebetcenter.org, thebetcenter.org.
Okay.
And it stands for Biofeedback Education and Training. So
Right.
thebetcenter.org.
Okay.
Yep.
Great. Well, I appreciate you guys. Finally, we made it
I
happen.
know. I'm so happy.
Yay.
Thank you so much.
Well, yeah. And so Kathy will actually watch an episode now.
Yay.
She has to now.
What? She hasn't watched an episode?
I always sweat her. Because she'll ask me questions, and then I go, "Oh, it's funny. We just had an episode about that, Kath. Thanks for
Oh, my.
Yeah,
My. She's
I
quiet.
sweat her. Yeah. But anyway, thanks for coming on. I appreciate it. We got our good friend Tony D coming in next week from Waco, Texas. Hopefully he brought some kolaches, because if not,
Kolaches and Branch Davidians. Hopefully he brought those.
right, both of them.
Yeah.
But anyway, thank you for coming out. I'm glad all the stuff worked today, and I'm glad you didn't have an episode.
Yeah. Well, we just filmed an episode, but I'm about to have an episode with you where I'm going to beat you.
Nice. Hey, everybody, be sure, like, subscribe, comment, all that good stuff. Chad's getting that all in. But remember, kids, there is no magic pill for sobriety, because if there was, we would all take too many.
Mm-hmm.